Greetings and welcome to the Quality Insights podcast for healthcare professionals. My name is Dawn White. I'm an assistant project coordinator at Quality Insights, and I participate on a team of staff dedicated to promoting and providing CME eligible opioid education sessions across the Commonwealth of Pennsylvania through our partnership with the Pennsylvania Department of Health. We have a great topic and conversation lined up today, focusing on Pennsylvania's opioid crisis, specifically related to maternal health and the upcoming release of new opioid prescribing guidelines from the CDC. With that, I'd like to introduce two guests who are here with me today. First, I'd like to welcome my colleague, Jared Garfield, who is a practice transformation specialist at Quality Insights. Jared holds a master's of public health from the University of Pittsburgh. He's involved in a diverse range of quality improvement initiatives in partnership with the Pennsylvania Department of Health, including reducing substance use disorder and assisting healthcare organizations and clinics in identifying and achieving optimal patient care. He's been part of the DOH's Safe Prescribing Education team since April 2020 and has played a role in the implementation of the program across the state. I'd also like to give a warm welcome to one of our clinician champions, Dr. John Gallagher. Dr. Gallagher practiced as an OBGYN in Western Pennsylvania for over 33 years. He is the former chair of the Pennsylvania Medical Society's Opioid Task Force. He has participated in development of PA Department of Health Opioid Clinical Practice Guidelines and implementation of the PDMP. Dr. Gallagher also serves as an advocate to the legislature, governor, and regulatory authorities on behalf of patients and physicians. Jared, I'll hand it over to you to get this conversation started.
Thanks so much, Dawn. Dr. Gallagher, before we jump into the CDC opioid guidelines, I want to talk a little bit about your background and what really drives your passion for opioid-related work. So could you go into detail about what really drives your passion for this work?
Well, Jared, and thanks for having me here today. I have to tell you that I really didn't have much interest in the opioid problem, except when I read newspaper for most of my career. Other than a small but steady number of pregnancies with substance use disorder in women that I had, as well as the occasional patient that appeared to be drug seeking, I didn't really have a large exposure to the opioid issue about 2013. At that point, I became the vice chair of the Pennsylvania Medical Society. And in that, one of my roles in that position was to chair our opioid task force. That group had been assembled around 2009 when the opioid epidemic was really gearing up with the mission to help direct the physician response to the issue. This was a period in which the legislature was actively trying to pass bills, many quite intrusive, to decrease prescribing, and physicians being blamed as the primary cause of the problems due to overprescribing and carelessness. So I had to do a lot of on-the-job training at that point. It fell to me and our advocacy team to educate legislators on the issues and the unintended consequences of the legislation they were pushing. We also focused that time on professional education, on opioid stewardship, and pain management. And of course, we had an active role at that point in 2016 and before developing PDMP and making it as useful and least invasive to clinical practitioners as we possibly could. In that respect, I think we really did a pretty good job. The results have been positive. We've seen about 40% decrease in opioid prescribing statewide, almost elimination of doctor shopping, and definitely an increased awareness for the health profession of the need for proper use of opioids. But at the same time, in some of our ways, the pendulum may have switched a little too far, as we now need to reassess our efforts. It's this need for constant reassessing and the central purpose of our work to find how we can work in the best interest of the patients. And that's what really keeps me going at this point.
Excellent. Thanks so much. And then just before we jump into the guidelines, I want to hear more about your career as an OBGYN and what aspects of your work did you find most rewarding and most challenging during your career?
Well, OBGYN is a great specialty. In fact, if you ask a lot of medical students, they'll say they love OBGYN and would go into the field if it wasn't for the hours, and that comes with the territory. But that is something we have to deal with and get used to it. But every specialty has its own set of problems that it has to deal with. But with our profession, we work with a generally healthy population over a long period of their lives, we actually become the primary care provider for a lot of women through most of their lives. We can become very close to them at the very beginning of when a young woman is first seeking contraception, and then as they're starting and raising a family, through to middle age issues that we have to deal with, and finally into menopause. We always tend to say that the patient ages with their gynecologist. So we start with young women and we retire with a lot of older women in our practice. I've had the opportunity to deliver babies to women, their daughters, and in a few cases, even to their granddaughters. In a small town like where I've lived all my professional career, families are always coming up to you, embarrassing their kids by saying, "Hey, this is the guy who delivered you." And they are bashful and don't know what to do. And, we just have to say something like, "Well, I'm just happy I didn't drop you on your head." So the hardest part, though, on the other side, was dealing, which was fortunately less often, with the dark side of pregnancy loss at any stage, which can be decimating to the family as well as the provider, because we're so involved in this. But because of the established relationship, you have to share the grief and often help them to move on, hopefully to happier times afterwards. So that's been a great career.
Excellent. Thanks so much for just that level of detail and some of the anecdotes. Moving on to the opioid crisis in Pennsylvania and its impact on maternal and child health. What do you feel is one of Pennsylvania's biggest gaps in care as it relates to maternal and child health?
Well, in terms of child health and pregnancy, identification of a pregnant woman with substance use disorder is probably one of the biggest problems we still have. We know that if we can identify substance use disorder at that first visit, or at least early on in the pregnancy, we can manage the patient, we can initiate medication-assisted treatment with either methadone or buprenorphine, and as a result, safely manage the pregnancy all the way to term. The neonate that can also then be observed for and treated more easily for neonatal abstinence syndrome. But in spite of national ACOG recommendations, we find this isn't still always done, especially at the first visit. Many of our colleagues only screen those people they think fit some kind of picture in their mind of what's going on. But we know that substance use disorder crosses all demographics and socioeconomic lines. So you really have to be open-minded and do a universal question at that point. We know that most women, if they're questioned early in their pregnancy, will be honest, but only if they feel their provider is open and non-judgmental. If they're not asked, they may continue to use the illicit opioids, risking overdose, maternal and fetal complications, hepatitis, and other infectious diseases, as well as leaving the newborn open to the risk for small gestational age issues, severe neonatal abstinence syndrome. So a lot of issues that we have to deal with. We know that opioid use in pregnant women has steadily risen along with the increase in the general population. In 2018, Pennsylvania maternal mortality report showed that the accidental poisonings, which include overdose deaths, was the leading cause of maternal mortality that accounted for more than 50% of all maternal deaths. In 2013, before we really kicked into this, accidental poisoning accounted for only 13% of maternal deaths. So that's a major change in the past couple of years. And we know in America, our maternal mortality rate is sometimes in the third world category. In many states, the rate of neonatal abstinence syndrome has doubled. And in states like West Virginia and Vermont, about 1 in 20 babies will experience neonatal abstinence syndrome. And we see no plateau in sight. Pennsylvania has among the highest NAS rates of the country and much higher than all our surrounding states, New York, New Jersey, Delaware. Only West Virginia is higher than us.
Wow, that is just really enlightening information and just really highlights the scope of the issue in that sense as it relates to maternal and child health.
And quite depressing.
Yes. So what do you perceive as one of the most pressing issues in Pennsylvania related to the opioid crisis generally? And what do you think healthcare professionals can do to address the challenge that is the opioid crisis?
Well, we've made progress on a lot of fronts. In Pennsylvania, I think there's only two main issues that we still need to improve. One is access to treatment. Once we recognize substance use disorder and we're able to convince the patient to seek help, sometimes we hit a wall. Pennsylvania is a largely rural state, and these areas often lack providers and services to treat substance use disorder. Urban areas, the wait for referral to care can be quite long, if it's even available at that point. The state has started several programs to increase manpower, including debt repayment to providers at all levels who go into substance treatment programs, especially if they go into rural areas. But 80% of substance use disorders have a coexisting mental health problem, like bipolar or depression. But in spite of this, we have so many psychiatrists who are already limited in number to begin with, who will not treat the patient while using opioids. If a county has no medication-assisted treatment provider, as is occurs in most of the state, a lot of it because the community doesn't want it in their backyard, it's unlikely that the patient is going to drive more than an hour daily to receive methadone. And then if they do, how can they maintain a job while facing the extra commute? So the Department of Health has offered hub and spoke training and management programs to providers, but trying to fit in these extra services in your busy practice really can be pretty impossible at times, especially if your covering physicians don't want to go along with you. So we have so much work to do on the access issue, and the same limitations affect referral, for evidence-based pain management for those patients with chronic pain. The other problem that we deal with, and I think we're seeing a lot of focus on that in symposia, both statewide and across the country, is the stigma associated with substance use. Both professionals in the community still harbor all these misconceptions and biases against people with substance use disorder. When I was trying to roll out Narcan programs into police and sheriffs back in about 2017, 2018, it wasn't uncommon for the officers to tell me they would not administer would administer naloxone to the patients because they felt the user would only use it again. It was a waste of their time and were better off without them. I had to fight that off a lot. A lot of times they were frustrated that they had to come back to the same residents repeatedly to treat the same people. People don't want treatment programs in their neighborhood because they think it draws the wrong type of people and increases crime. Those are statements that we've repeatedly shown not to be true, but we have to work and try and change people's minds on that. We are making progress. When I first started speaking to the public on the issue, I would ask how many people in the audience knew a relative, a friend, or coworker who had overdosed or had a drug problem. At that point, probably 1 out of 10 people raised their hands. Now, when I ask the same question, almost everyone in the audience has had that experience and realizes that's not just a problem of what they like to refer as those people, but it can affect anyone at any time. And what can professionals do? We need to reinforce that substance use disorder is not a personal choice or a moral weakness. It's a medical issue, just like diabetes and hypertension, that must be identified and treated, and that patients have the same compliance issues that they have with other medications. Whether it's getting to take their antihypertensive or getting to take their buprenorphine, we deal with this all the time. Radiologic studies, like using MRIs, have shown that the brain of a dependent user has been permanently altered. And with treatment, it can be improved, but never returned to normal. And 80% of substance use disorder patients report that prescribed opioids were their entry point to misuse. Some by diversion, but most prescribed for legitimate purposes. So that's what we're really focusing on at this point.
Excellent. Thanks so much. And I wholeheartedly agree that, access to treatment and, making these resources readily available so that, everyone in any part of the state can access them is crucially important. Moving forward to the draft CDC opioid guidelines, with the new addition of subacute pain, how would you weigh prescribing the lowest possible dosage to patients against variation in patients' pain thresholds?
Well, one of the things they came up in the guidelines, and I'm not sure what the final guidelines will be yet because they've just been published and public comment period is just ended, so they can be revised and we'll see what comes at the time. One of the things they did is they brought up the subacute category, which I don't think really adds much to the new guidelines. It's just a period that meets the acute pain of the 1 week to 1 month to the 6 months where chronic pain comes in. So it's at that 1 to 3 month area. But when we start the opioids, we have to be careful and we always have to use them when needed and using the lowest dose of a short-acting opioid. In the hospital setting, we now know that we can individualize the amount of opioid we use on discharge by looking at the amount of pain that was required for in-hospital pain control. So if the patient didn't require opioids and had adequate control with acetaminophen, non-steroids, whatever else you were using, why would you want to send them home with opioids just in case? If there was a change in the patient, they could always be reevaluated, given opioid if needed at that point. That's why the follow-up care becomes so important. Studies have demonstrated that we have long overprescribed opioids after surgery. I'll tell you, we just had the personal story that came up. My wife just had foot surgery done last week. and got a prescription for 6 Percocet tablets in case she needed it. And we look back, and I had had the exact same surgery before in 2013. At that time, the orthopedic physician gave me 50 Percocet tablets for the same surgery. So we're really looking at it differently now than we did before. And there were good reports in several different types of surgery that showed the average opioid consumption by patients post-operatively was only 3 5-milligram oxycodone tablets. So then why did we always give 30 or more tablets? That was our way we were trained, and we have to retrain ourselves to do different. This same concept does apply to office pain. The risk of developing dependence is directly related to the dosage and duration of the prescribed opioid. So we think this is one area where we can have marked improvement in our prescribing practices.
Excellent. And then just moving forward to MME, CDC has removed that 50 to 90 MME guideline and replaced with caution at any dose. Do you agree with this change? And then why or why not?
Well, they really didn't remove the guidance. What the CDC did is they removed the dosing limits of using 50 as the, what recommended and trying not to go above 90 from the summary statements, because legislators and insurers had interpreted these as fixed mandates. And we got all these laws that were passed that said you had to get not use that kind of prescription and what was going on. And insurers went with pre-authorization and made it so much more difficult for us to do that. And it prevented clinicians from using their clinical discretion. So the new guidelines put the dosage levels into the body of the discussion. So they're still recommended. We know that there's no clinical evidence of improved efficacy when using opioid doses over 50 morphine milliequivalents. There's absolutely no evidence of benefit over 100 morphine milliequivalents. Yeah, I would see times where patients would come in on 200 to 500 morphine milliequivalents every day. I would really get my stomach would twist in knots when I saw that, especially if they were being co-prescribed some other medications. At that risk, at that range, the risk of overdose is probably about 3.7 times higher once you go above 100 morphine milliequivalents. So, and also when they're going those high doses, we'd have to make sure we consider giving those patients Narcan for their own safety because of the increased risk of overdose. I would also recommend those patients may look otherwhere for other physicians because I thought that was a little careless prescribing at that point. Although again, we have to individualize. So these are the patients that the guidelines are really addressed to.
Gotcha. And thanks for that clarification initially. Is there an aspect of the guidelines where you find that there's the most room for interpretation, or do you see like a gray area anywhere in the guidelines?
Well, guidelines are really long. Again, you can read I think there's 8 or 12, I forget the actual number, of specific summary points that they make. And that's what a lot of people read. The actual document is well over 160 pages, but it's full of really good information. But in there, I think there are 2 changes that I think may be confusing. In the prior guidelines, the CDC basically recommended against co-prescribing benzodiazepines with the opioids due to the synergistic increase in overdose of about 2 to 4-fold when that was done. In the new guidelines, they say use caution when co-prescribing, which may lead to an increase in using the combination and the subsequent risks. This is especially important in the elderly, where they're much more sensitive to these medications. So that does concern me, as some providers may not be as cautious as others would be. The second change is that when substance use disorder is identified, the clinician should offer or arrange for treatment, including medication-assisted treatment. In this case, should be interpreted as a requirement rather than as a suggestion. Although it's definitely the right thing to do, there may be some difficulties in referral, as we discussed before. And if the provider does not refer, he could be facing accusations of not practicing standard of care. So we want to encourage providers to recognize and refer. And that's actually one of the things we cover in Module 5 of the opioid series that we offer through Quality Insights. But I think this may be a high bar to maintain.
Excellent, thank you. And finally, what's your biggest takeaway from these guidelines, and what key takeaways would you highlight to prescribers?
Well, there's nothing in the proposed changes that I would consider revolutionary. So what I think is most striking is that we actually have been doing the right thing since the original guidelines in 2015. These new guidelines address the concerns of physicians that they are only recommendations and shouldn't be taken by legislators and insurers as fixed mandates, which will be a big help. But they are well-researched and documented best practices that, if followed, I think are going to allow physicians to treat the patient in the most effective contemporary manner. Many physicians will just read the summary guidelines, but as I said before, I recommend that everyone working in the area of pain management at all levels read the supporting documents, as they have a wealth of information which will facilitate providing optimal care to every patient in both acute and chronic pain situations.
Excellent. Those are all the questions that I had, Dr. Gallagher. So thanks so much for all of the detailed information and the answers that you provided. Dawn, I'll turn back over to you.
All right. Thank you, Dr. Gallagher, for joining us today and sharing this timely information with us and our audience. The education team at Quality Insights is readily available to answer any questions you may have related to the topics we discussed today. If you would like to get in touch with us, please send us an email at pdmpeducation@qualityinsights.org. As I mentioned at the start of today's show, Quality Insights, in partnership with the Pennsylvania Department of Health, offers more than 7 different continuing education modules on a variety of topics related to addressing Pennsylvania's opioid crisis. We invite you to join us for one of our upcoming live webinars, or contact us directly if you'd like to talk about ways you can offer complimentary opioid-related learning sessions in your healthcare setting. We want to thank you for your dedication to providing quality care to the patients you serve. We look forward to seeing you on an upcoming presentation or podcast.